Okay, thank you very much. Well, good evening, everybody. Thanks for coming along. And congratulations to those of you that managed to put the brains back together. Pretty successful all around. Okay, my name's Steve. I'm a neuropathologist at Imperial College. You've heard from Nell all about the work going on brain tumours. One of the other aspects of our work, I'm particularly interested in neurodegenerative diseases like Parkinson's and Alzheimer's disease. One of our roles is we're funded by the Multiple Sclerosis Society and Parkinson's UK to collect brains for research. And to do that, they've set up the tissue bank at Hammersmith Hospital. And I'm just going to run you through the process of what happens in terms of donating a brain for research. Take you through the process of what goes on at Hammersmith. I'll then show you a short video, a nice guide on how to dissect a brain. And then I'm going to ask you, well, why are we actually doing this? So I want some answers from you. So anyway, the charities have funded us to set up the brain banks, and what we do is we have a lot of events with the charities explaining why brain donation is so important, and people will sign up. So these are patients with the disease, and often their spouse as well, because all scientific projects you need controls. So we need controlled brains as well for comparison. So the patients, while they're alive, they sign up that they would like to donate their brain when they pass away. So when that does happen, while they're signing up, we also get the next of kin to sign up so that they are aware of those wishes. And we get the instructions both to them and to the medical staff that when they do pass away, they need to get back to us as soon as possible. And in fact, we're on call 24 hours. So we get calls at, people tend to die at 3:30 in the morning. So we get calls on the 24-hour bleep, and we then have to arrange a retrieval somewhere in the country. We cover the whole of the UK. Now, for research purposes, we need to get those brains within 48 hours, preferably within 24 hours, because they have more research usage. So a brain that's collected in under 24 hours, brought back to Hammersmith and dissected, can be used for genetics, biochemistry, and a lot of different experimental approaches. Those brains from 24 to 48 hours are more structural pathology type projects. So they're equally useful, but for different things. But we do try and get them back very quickly. I think our record is a donation from an MS patient in the Shetland Isles, which got back to London in 19 hours. And that was going some. We send our technicians all over the country on the trains with their M&S cool bags. So if you ever see someone on a train with an M&S cool bag, just don't ask. Okay, so we get them back to Hammersmith Hospital. If it's under 24 hours, what we'll do is we'll dissect the brain. Half of the brain will be frozen. It's frozen, it's photographed, it's sliced, it's photographed. Little 2-centimetre blocks are then put into the freezer, and because we've got the photographs, when people ask us for a tissue from a certain anatomical area, we just go back to the photos and say, well, it's block B3 on that slice, and that goes out to the researcher. If it's 48 hours or it's 24 hours, half the brain goes into fixative. So this is formalin, which stops the brain tissue rotting, fixes it and makes it useful for structural studies. So about 6 weeks after a brain has been fixed in formalin, it comes to me or one of my colleagues, there's 3 of us that do this. On a Friday morning, we go in and do a brain cut at Hammersmith Hospital. And what we're doing, and I'm going to show you that process in a minute on one of the videos that we made with the Wellcome Trust last year. We dissect it, we take specific blocks of tissue, they go off to the technicians who cut sections, stain them, and then give me a box of about 80 sections. About a couple of weeks later, I then have to do a neuropathological report of what's happened in that brain. And that goes out to all the researchers using the tissue because they need to know exactly what was happening to be able to interpret their own results. And the problem, particularly with Parkinson's disease, in the age range where people are dying, they often have more than one pathology in their brains. So you need to know all those confounding pathologies to make use of that tissue. So yes, that's pretty much it. It's either frozen or it's fixed. Just a little bit more on the preparation. While doing this fresh dissection, we make a cut through the midbrain here, and for a Parkinson's brain, even before you see any clinical notes or anything else, you start to get a hint as to whether this patient had Parkinson's disease, because one of the key pathologies is in this area called the substantia nigra, the black substance. And in this person over here, you've got a very obvious black line, so very unlikely to be Parkinson's. Over here, it's faded, and they've lost those cells in the substantia nigra. And that's quite specific to Parkinson's-like disease. So it gives us a bit of a clue, even when we're doing the macro, the cut-up, as to what we might be dealing with. And then, of course, we have a whole screen of histology slides, very thin, 6-micron sections, which are stained up with various key stains which help us make that diagnosis under the microscope. So I'm just going to stop that there for a second and see if I can find the video. As I say, this was a video made by the Wellcome Trust for their brain exhibition last year. Basically, they came in and filmed one of our Friday morning sessions, and I'm hoping it's going to work. Right, when it was on the screen at the Wellcome, there was no commentary of what was going on, so that annoyed people. So they came back afterwards a few weeks later, and I did a voiceover in my office. But now if you go on YouTube, you can find this with the voiceover. But I thought I'd do it live today. So that, as you saw, was a whole fixed brain. This is a charity-funded operation. Oh dear, right. We'll get on to this in a minute. Right, this is in the cut-up lab at Hammersmith Hospital, Burlington Danes building. There's my colleague, Dr. Ilaria Bravi, a neuropathologist. And what we're doing is our regular cut-up. So these are full fixed brains. I've just taken the spinal cord out there as well. So particularly for a disease like multiple sclerosis, it's good to look at the spinal cord, because the disease pathology can affect the spinal cord quite badly. So the first thing we do, we have the whole brain, is we look at the external surface. Are there any clues to what might have gone on? So when I'm holding that, you'll feel the surface, you're feeling for softenings. That's often a sign of a stroke. So if there was a stroke just before death, the tissue starts to liquefy somewhat, it feels soft. So you have to feel the brain, that's the first thing you're going to do. Then you're going to look for signs of any shrinkage. In these diseases of old age, the brain can shrink, can end up looking a bit like a pickled walnut, really very, very thin areas here. This one's got a little bit of mild atrophy in the frontal lobes, which is quite common in Alzheimer's and Parkinson's disease. What I'm doing here now is I'm removing the blood vessels at the base of the brain, the ones that supply the brain, and looking at those gives me a little bit of a clue to lifestyle straight away. A lot of disease in that basal circuit, atherosclerosis, hardening of the arteries, and that's usually down to one of three things, or a combination of smoking, high-fat diet, and no exercise. All of those lifestyle factors will affect the basal vessels. So this was a Parkinson's brain, so I've made that first incision through the midbrain. I'm now looking at the substantia nigra again, and it's a little bit pale. So again, this is looking like it probably was a correct diagnosis in life. And I'll come on to why that's important when we go back to the slides. So now we need to do a survey through the whole brain, so we have to take slices. It's just a glorified bread knife. And we go through our landmark is something at the base of the brain called the mammillary bodies, which is part of the hypothalamus, the part of the brain that does all the housekeeping. So that's our reference point. So that's my first cut there. And immediately I'm going to start looking at those cut surfaces for signs of any pathology, any tumours, any stroke, With multiple sclerosis, you're looking for discoloration of parts of the brain where the pathology is, in the white matter, where the nerve cells have lost their insulation. And because they've lost that insulation, they don't function as well. Because MS is a random process, the presenting symptoms of multiple sclerosis can be very, very varied. And it's really only after you've had two separate episodes that the neurologist is likely to come up with MS as a diagnosis. I'd love to say I had a perfectly steady hand that could cut half-centimetre slices. I have to cheat and use this guide. So that gives us our first slice, a half-centimetre slice. And the reason we have to cut that thinly is that some of the key anatomical areas that we need to look at are very small. And if you had a very thick slice, quite often you'd miss them. So we have to have these thin slices. As you see, Ilaria has done a beautiful job. She always gets perfect slices. When there was no commentary on this video at the welcome, I was actually asked by someone, were you racing each other? No, we weren't. So there we are, the whole brain laid out in nice coronal slices. Then what we need to do is sample those key areas which are going to allow us to make a diagnosis. And there's Ilaria is just cutting out one of the blocks here, as you'll see, and there's another one being cut out here. These are key anatomical areas we need to look at to make sure we don't miss any pathological processes. And as you can see just along here, we have these little cassettes where we put that tissue in, and the technicians will take those away. They'll embed that tissue in paraffin wax. So putting those blocks in the cassettes there are 20 of those for every brain. We need to look at slides from 20 regions to make sure I know exactly what pathology there was in that brain. There are little sections of spinal cord there. When people come along to a live dissection, that's what upsets people most, is the dissection of the spinal cord, because in life, that is just horrendous, to transect the spinal cord. You know what that means. And that's the end of the process there. So a quick guide onto how to cut up a brain. Okay, can we get back to the escape? Okay, thank you. Right, okay, so now you know how to do the dissection, but why do we collect brains? Okay, before I go on to the next slide, it sounds like a stupid question, but why do we collect brains? I've got 4 reasons on the next slide, so you tell me. Sorry? A little bit more specific. For research. Okay, well, that's the obvious one, number 1. Okay, we're looking for understanding of the disease process. Yeah. Anything else? Yep. Absolutely. Clinical audit. What a lot of people forget is that pathology, that's the reason for pathology, is find out what went wrong and feed it back to the clinician. Particularly with brain disease, it's very difficult sometimes to make a diagnosis clinically because it could be so many things. And when you pathologically have confirmed what it is, giving that information back to the neurologist is very valuable to them for their diagnostic practice in future. They will have learnt from that case, particularly the difficult ones. So clinical audit, yeah. Anything else? Slightly more practical, related to what Nell was talking about in terms of what she wants to do now. Clinical trials. It's all very well having a drug to treat a brain disease, but actually you need to find out whether it worked or not. And I'll come back to that in a minute. Okay, so those were my 4 reasons. To understand how pathology affects the brain, get an idea about what causes diseases, clinical audit and clinical trials. So if we look at the first one, we use this tissue for research. We use it for ourselves as well. The tissue banks are charity funded and we are providing tissue all out throughout the world in the UK. We're not completely altruistic, we have our own research teams as well. But the type of research being carried out on the Parkinson's tissue is broken down here in this little chart here, the kind of projects that are going on, the areas that are being looked at. The olfactory system, why? Well, interestingly, Parkinson's disease and Alzheimer's disease, one of the earliest symptoms is a loss of smell, because the pathology affects that part of the brain just at the top of the nose there. Not very good diagnostically because it happens with multiple diseases, but a loss of smell is often a presenting sign. Well, we've got other things there which I won't go into in detail. So, Parkinson's disease. Many of you will probably know somebody with Parkinson's disease. It's very common. Classically, it's a motor disorder. It's a problem with movement. Classically, you will present, I think many people will recognize the pill-rolling tremor, a little bit of tremor in one arm, or bradykinesia, inability, particularly in the elderly, sitting in an armchair. They can't initiate the movement to get up again. And that's all down to this problem with the motor system. But actually, we now realize that Parkinson's pathology is much wider than that. And if you live for 8 to 10 years with Parkinson's disease, you're going to start showing non-motor symptoms, cognitive changes, a bit like Alzheimer's disease, memory problems, decision-making problems. And that's because we now realize that the pathology spreads through the brain slowly in a very stereotypical manner. So all this is showing you is the classic Parkinsonian gait, slightly hunched forward, a little bit unsteady on your feet, so you tend to shuffle your feet forwards, and that's the motor problems. There is a brain from somebody who had long-standing Parkinson's disease, and you can see it's really quite shrunken. So this person also had memory problems, personality problems. And under the microscope, it's all about these little things in the nerve cells. These are called Lewy bodies, and they're killing the nerve cells. So, I showed you earlier on, the classic place for pathology in Parkinson's disease is the substantia nigra. Should be nice and black. Here, it's almost all gone, and this was from a Parkinsonian patient. One thing, bearing in mind the average age of the audience here, you have to be careful you know the brain that you're being given, the clinical details, because someone in their early 20s would have a pale nigra like this because you haven't had a lifetime of laying down that black pigment. So it's not just Parkinson's, it could just be you're young. So what this has allowed us to do, we've now seen 650 brains through the Parkinson's Tissue Bank since 2003. And what that allows, because I've seen pretty much all of them, what it allows you to do is see patterns of pathology. And what that's allowed us to do is get a much better idea of how extensive the pathology is in different patients and how it progresses. And things like, where does this pathology start? If it's progressing, where does it start? Well, it appears to start down here in the brainstem, but it may be even more peripheral than that. There are suggestions that the pathology develops in the peripheral nervous system, for example, in the nerves supplying the gut. So, bizarrely, and you can actually see this pathology in these peripheral ganglia. Bizarrely, one of the presenting symptoms of Parkinson's disease, in retrospect, is probably constipation. Interrupting normal gut activity because you've got pathology in those ganglia down there. Again, not very useful diagnostically because there are umpteen reasons for constipation in the elderly. And the other thing we can do, because we've seen so many patterns of pathology, is start building up patterns of what pathology relates to what clinical symptom. So in this particular paper we did a few years ago, there are certain parts of the brain that if you get this pathology, you're likely in life to have had hallucinations. So not only do we learn about the disease process, we also learn to some extent a little bit more about normal functioning of the brain. Okay, hypotheses related to what causes these diseases. To some extent we have a problem, particularly with diseases of old age. By the time we get the brain, we're looking at an end stage process. Everything that's going to happen has already happened. doesn't really tell us what kicked off this process in the first place. So we need to understand more about the early processes. For something like Alzheimer's disease, the pathology has been developing in the brain for 20 years before you start showing any symptoms. So in the future, there are two big targets for drug companies. One, stop the disease process, find a drug that will do that, but also get to patients before they're symptomatic, i.e. we need a biomarker which says this person's getting Alzheimer's disease even if they haven't got any symptoms. So we need to get that drug into them because sadly with something like Alzheimer's disease you're never going to reverse it. If you've lost memories, you can't put some more cells in and get those memories back. Memories are unique to your life experience. You can't reprogram them. So we really do need to get in with this particular disease before they become symptomatic, if we can. So there are various ways of doing that, and by looking at the brains, together with genetics, this is a fairly rare type of dementia called frontotemporal lobar dementia, FTLD, and there are certain subtypes of that. And by bringing the genetics of families with this type of disorder, genetics and the molecular biology and the pathology, new disease subtypes have been described, particularly in the last 5 years for frontotemporal lobar dementias. We suddenly understand a lot more about the protein deficits, we've seen the pathology, and it correlates with the genetics. We know a lot more about these particular diseases. One of my research interests for a long time has been the link between head injury and the subsequent development of degenerative disease later in life. And I was particularly interested early in my career in Dementia Pugilistica, punch-drunk syndrome. I don't think it really takes a rocket scientist to work out that repetitive blows to the head, particularly with a force of half a metric ton, which is apparently what that was, is not good for the brain. And sadly, there's a proportion of boxers who develop Dementia Pugilistica 10 to 15 years after they retire from the ring, so mid to late 40s, probably 15, 20 years earlier than other people with Alzheimer's disease. And so that was an indication that trauma may kick off the pathology of Alzheimer's disease. That was back in the early 90s. The Americans have just rediscovered this, and they've decided to call it chronic traumatic encephalopathy. The big thing in the US at the moment is American football players. There have been a number of very high-profile deaths. One of them was a suicide in NFL players in their late 20s. And one of them recently left a suicide note saying, "Please look at my brain." And very deliberately, the suicide was a gunshot to the chest. He didn't want to damage the brain. It was that focused. And Anne McKee in Boston did that PM, and lo and behold, had some pathology that looks a little bit like Alzheimer's disease. The problem at the moment is we've only got N of 1 or 2, the number of cases we've looked at. We need to look at this in much more detail to see this. And it's a huge public health issue in the States particularly, not so much with the NFL. They're paid millions of dollars a year to go and smash into each other. It's the high school kids playing this. Are they damaging their brains earlier on? So there's a real public health issue. And it's only by looking at post-mortem brains that we can make these links. So, clinical audit. Just going back to Parkinson's disease, Parkinsonism is how you describe the clinical presentation of Parkinson's disease. Unfortunately, there are umpteen different diseases that can give a similar clinical presentation, the similar motor problems. So drugs can induce Parkinsonism, and you may know the story of the designer drug fad in California in the 80s, designing new drugs, and unfortunately one of these, called MPTP, ended up causing Parkinsonism in a whole series of young people. And it's actually now used as a model for creating Parkinson's in animals. And that was causing death of those substantia nigra neurons. There are a number of other degenerative diseases which can have Parkinson's presentation. So of the brains that come into our tissue bank, with a diagnosis of Parkinson's disease, 10% don't have Parkinson's disease. And the only way you can actually tell that is by looking at the brain post-mortem. So there's this list here, and there's 20 other disorders down the bottom there, all that can present like Parkinson's. And that's not knocking the neurologists, it's just impossible to tell clinically while the patient's alive precisely what's going on up here. And this just gives you a little idea of our approach to the diagnostics. This was one of my colleagues in the US, Dennis Dixon, put this protocol together back in 2006, I think. So this is way out of date. We have far more branches, particularly down here in the frontotemporal lobe of dementias. But what we have to do is work through and look for all of these various diseases to make sure these changes aren't present in any brain that we're sending out for research. So Lewy body disease, which is the Parkinson's disease, is just one of these boxes. Alzheimer's disease up here. And then all the way down here, there's the box that we all hate. It's a diagnosis of DLDH. Any idea what that is? It's dementia lacking distinctive histology, i.e. we haven't got a clue what's going on. So there are still cases out there that we need to explain. Finally, and something I think we're going to see more and more of as drug companies come up with drugs. Unfortunately, in the neuroscience sector, the drug companies have burnt their fingers a little bit. They've tried drugs, they've got to clinical trials, they've failed in clinical trials. So there's a little bit of a reluctance for brain disease, but they will come back. And what's important is that you must have neuropathology as an end point in a clinical trial. Now that sounds a bit strange. You, as a physician, you're trying to put your patient on this wonderful new drug that you hope's going to stop their disease, but when it doesn't, can we have your brain, please? It's difficult, but I've been to a number of lay meetings with people with Parkinson's and their carers, and they want to be asked at that time. The only difficulty is who should be asking them. 50% say, I want my physician, I know them, I trust them, I want them to ask me. Equally vociferous is the other 50% that say, no, 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 don't want my doctor asking, get someone else to come in and do it. So there are real practical issues about this. But you will see that this request, you know, it's not compulsory at all, but you'll find, and we have a slightly English approach to this, we don't ask. And the experience up in Scotland, there's a sudden death brain bank in Scotland for control brains. And they're quite bizarrely, as far as most people are concerned, they have the Procurator Fiscal's office contact the hospital every morning saying which people have come in overnight, unexpected deaths. So the Procurator Fiscal in Scotland is the same as the coroner here. And they get a list of these people who've died. They cold call the relatives of these people and say, can we take some tissue for research? They get a 95% acceptance. And, you know, intuitively, what? But actually, if you think about it, and we see this a lot with our donors to the Parkinson's tissue bank, when the next of kin rings me up at 3 in the morning and say, my wife's just died, they are desperate for something good to come out of that event. And it really is our responsibility to do the best we can to go ahead with that retrieval. It's their will, and that's what we do. And, you know, we are meeting their wishes. So perhaps it's not a big surprise, but one of the big issues is, how do you ask people? It's not something you can do. It's not a trivial skill to ask somebody this question. But you can train up people, and there are now liaison nurses, many who were trained up for the transplant service, because that's a very awkward conversation with someone who's effectively dead in ITU, being kept alive by machines only. Having that conversation with a family about transplant is not easy. So there's a real training component to that. But I think you'll see more of that, because actually most people are amenable to that request. They want something good to come out of it.